so much. Hello, everyone. This is Ben. I'm the CEO and co-founder of Aztron, and we're advancing percutaneous Achilles tendon repair. But to really start with, I would like to start with Dr. Wang. He's one of our co-founder. He's a president of Foot and Ankle Society in Taiwan, and he's a surgeon that started developing the technique. But that was really back to 20 years ago, where he see there's an open where the Achilles tendon still it's an open repair. And as we know on the literature and the actual situation with Dr. Wang is that the complication rate is really high. It's from 15% to 20%, which including rupture, nerve injuries, and infections. Most importantly, and patients suffer from pain and long time for rehab, and the function outcome was just not that great. So Dr. Wang starts developing techniques and start navigating what is the best solution, what's the better solutions, not to have to open it up the incisions, but while being able to visualize it and repair the tendons minimally invasively. That's why he started using ultrasound to visualize the tendon, just to using the ultrasound guided minimal invasive technique to repair the tendon. And 10 years later, me and Eileen and Dr. Wang, we co-founded this company and started building devices, building devices that can be integrated with or without ultrasound for the tendon repair minimal invasively. So here we are, we have the TendMIN grasper and then telescoping needle, which is a single-use sterilized disposable kit that can be integrated with suture anchor, suture tape, ultrasound, and then to this point, we do have surgeon not using ultrasound, and we have surgeon using ultrasound. So we provide the freedom for surgeon to use the technology or the devices. I'll quickly run through the technique or the whole devices introductions. But I'm pretty sure that Dr. Vosseller and Dr. Garras will be talking about that later. So we have the TendMIN grasper. So this grasper is using to retrieve the needle and then to retrieve the suture. So pretty intuitive. Basically, we just need to press the button to open the jaw. And once we get the needle and then we pull the trigger, just lock the needle inside the grasper so we can retrieve the suture without cutting soft tissue. So press open and then pull the trigger to lock. Secondly, we have our telescoping needle, where there's a removable tip where we can shuttle the suture from the loop to the tip. So simply just pass the suture into the guard or a suture tape into the guard and pull the tip of the needle, where there's going to telescoping the suture to the other side. And if we're using ultrasound, we'll be using ultrasound longitudinally to identify the tendon and then the rupture site, as well as the healthy portions. And by rotating axially, we'll be able to visualize the oval shape or the cross-section of the tendons. And so surgeon will make a small step incision just slightly proximal to the rupture end, and using ultrasound to visualize the cross-section of the tendon. Then we'll pass the needle right into the center of the tendon, where we're just making sure that we don't get a cut through by pulling the suture. So then later we'll be passing the suture and using our grasper to retrieve, grab the needle, and then to retrieve the suture from the proximal side as well as the distal side. That goes to the medial side again, just to go in and then grab the needle and then pull the suture out. So we'll complete that the procedure by passing this needle and then suture multiple times on the proximal side, and surgeon have the freedom to decide if they want to. So this one does the same on the distal end, but just want to quickly go through that. We can actually put anchor inside, or surgeon want to do end-to-end repair with two locking construct. That's definitely valuable for two options or multiple options for surgeons. So here's some case highlight that we can see that the incision is less than 1 centimeter. And this is Dr. Abek's case, 13 weeks post-op, and then patient will be able to do 20 signal hair rise with hiking 2 miles 13 weeks out. And we do have publications of showing that we can significantly reduce the complication rate and definitely enhance the AOFS ankle score and patient satisfactions. And if you are interested into the publication, we'll send it to you. Just reach out to us and we'll send it afterward. A short introduction about Aztron. We founded in 2020 first, and we started developing the technique at NTU, National Taiwan University, as well as UC Berkeley. And then we have the FDA listed this year and start commercializing the products. Currently, we have almost 80 we have more than 80 cases built, and we are focused on clinical data and then further collaborations. So that's a short introduction about Aztron. And then some of the housekeeping before moving to the talk is that please type your questions or thoughts into the comment or the Q&A sections where you can click basically the lower bar. There's a QA section where you can type your question, and then we'll be gathering the questions and then asking the question to moderator. From moderator to Doctors Vosseller and Dr. Garras later on. So with that, without further ado, Dr. Vosseller, please take it away.
All right, thanks, Ben. Let me just get things pulled up here. All right. So yeah, I'm Dr. Turner Vosseller from Jacksonville, Florida. And I'm excited to talk about Achilles tendon ruptures and kind of how and why my practice has changed, and specifically the role that Aztron has played in that. So just as far as kind of background information, we'll go over Achilles ruptures in 2025, almost 2026 now. So we'll talk a little bit about background and just kind of set the stage a little bit, talk somewhat about pathogenesis, just to get the basics kind of out of the way. And then we'll talk about general outcomes just in the general population and about in some specific populations, most notably athletes. And then we'll shift gears and talk about, the surgical treatment, which is obviously the fun stuff, and what issues we can encounter with that, specifically with respect to wound issues, which is certainly the principal concern with any Achilles tendon surgery, and then also the sural nerve issues that sometimes we can encounter with certain minimally invasive techniques. So getting to it, so I was a classics major in college, so it was maybe fated that I was going to be interested in Achilles ruptures eventually. I've read the Iliad certainly multiple times, but historically this was an injury of young men, although there's some evidence to suggest that the age has increased over time. The average age is actually in kind of the mid-40s at this point. And there's actually an increased incidence in women more recently, probably as a result of Title IX in the US. And as we'll go over a couple times, a rupture is ultimately a byproduct of a tendinotic degenerative tendon that undergoes an uncontrolled eccentric contracture. So what places you at risk? So like I said, it's an eccentric contracture, and these are typically tendons that are degenerative in nature. So we think longstanding tightness of the gastroc may play a role in why they become degenerative. And eccentric contractures are just things that occur commonly in sports, which is why we see such a large proportion of these injuries occurring with athletic activity, upwards of 80% or more. And the most common sport worldwide is likely soccer. In the US, it's probably basketball, although football's close behind. So whenever I talk about Achilles ruptures, I always include this study because I just think it's an important study and one that really helped me understand these injuries. It's by Nicola Mafuli, who's a surgeon in the UK. But basically, he took histology from three sources: from people that had normal tendons that had never had a problem, people that were having surgery for symptomatic tendinopathy, and people that are having surgery for an Achilles repair. And he assigned a histologic grade based on just how degenerative they were. And the Achilles rupture samples were consistently the most degenerative tendons. And so that suggests that the degeneration plays a role in why they ruptured. However, that runs up against the clinical reality that most people that we see with Achilles ruptures have no symptoms beforehand. They don't have any pain or anything. It just have a catastrophic injury. And so we wanted to look at that a little bit. So this is, as I'll go over a little bit, this was a bit of a staged picture of me doing ultrasound there, because I don't use ultrasound very often, although I'll circle back on that in a little bit. But in this study, we basically just did ultrasounds of a bunch of patients at risk for Achilles rupture, which are primarily medical students and residents. And we found that there was a 16% rate of asymptomatic tendinosis in these patients, meaning that there are plenty of people that are at risk for this injury, even though, once again, they don't have any symptoms. So if we shift gears and just talk about outcomes from these injuries. So the outcomes, there's a lot of things that we don't love about it. I mean, basically, it's one study out of Denmark at 1 year follow-up or 12 months noted that muscle strength, endurance, and patient-reported outcomes were not normal or didn't reach normal levels by 12 months. Secondarily, the study out of Finland noted that there was about a 10 to 15% loss of plantar flexion strength, and that seemed to correspond with a muscle volume deficit in the calf, and that was a rarity in orthopedics, a long-term follow-up at 14 years. Um, and so, we would certainly like for those things to be better. But what about in certain populations? And, I mean, obviously here in Jacksonville, Florida, we had, one of the quarterback for the opposing team had an Achilles rupture this past weekend. And as you know, these can be devastating injuries for athletes. So we, we looked at this, and there's a lot of studies that have looked at Achilles ruptures in professional athletes, but we wanted to be objective and rigorous about it. And so we actually did two studies. We did this one looking at the major professional sports in the US, the NBA, NFL, Major League Baseball. We also looked at the National Hockey League also, but there were no athletes that met our inclusion criteria. And then we did a second study. The first one was published in AJSM. This one was published in the Orthopedic Journal of Sports Medicine, looking at specifically at soccer players, Major League Soccer here in the US, the Premier League in England, La Liga in Spain, the Bundesliga in Germany, and Serie A in Italy. And basically, we looked at pre-injury statistics compared and the injured player compared to 1 and 2 years after injury. And then we compared that to control players who had similar statistics before the injury and looked at it afterwards. And it was interesting because in both of those populations or in both of these studies, the return to play rate, once again, was about 70%. I mean, we don't love that. We'd like for that to be higher, certainly. And in the injured athletes, performance, unsurprisingly, was worse at 1 and 2 years after the injury than it was pre-injury. But when they were compared to control players by the second year after the injury, their statistics had normalized. So there wasn't a statistical difference between their statistics versus control players, which suggests that it's just a long recovery. It takes a long time for them to return to normal function. So if we kind of talk about surgical treatment of this injury in 2025, what's our goal? I think it's important with any surgery that I do to be kind of intentional about stating what it is we're trying to accomplish. And so with this, it's really pretty simple. I mean, you want to restore normal tension or restore appropriate tension. And that's it. I mean, that's really what we're trying to do here. And from a treatment standpoint, we're trying to maintain that tension. So obviously we want a strong repair so that we can do that. And I would say that, Dr. Garras will get into this kind of at length, but I think you have a lot of flexibility with this system that allows you to put in different suture configurations, and you're not necessarily stuck with a guide that's going to make you do it in a certain fashion. So you have flexibility to put in extra locking stitches or something like that if you want. But in any event, we're trying to restore normal tension, and obviously we want to minimize the risks of doing that. And the risks are really going to be twofold. I mean, anyone that does any volume of Achilles tendon surgery, we know that the wound is really the principal thing we're concerned about. And obviously, smaller wound, less risk. And obviously, the sural nerve can be an issue just because of its proximity to the tendon. So let's talk about that a little bit. So we actually did a study where we went back and looked at an open approach, which is how I used to treat these eons ago. And when I first started doing minimally invasive approaches, and in our study, the minimally invasive approaches had no wound complications, whereas there were quite a few in the open complications, occurred at a much higher rate. There's also, this is a systematic review and meta-analysis, which was included a number of kind of high-ranking authors, if you will. Mark Meyerson was an author on this paper, and I'm probably gonna say his name wrong, but Doogie from Qatar and Jason Barreto, so a lot of smart guys. And they basically looked at open versus minimally invasive approaches, and looked at the infection rate and looked at other things too. But if there was any compelling data that you're going to see here, it's the superficial infection rate was 15 times higher with an open approach. So clear advantage of a minimally invasive approach over an open approach. And the deep infection rate, like it was in our study, there were none. I mean, there were none in the minimally invasive. This included 10 randomized controlled trials. So it was several hundred patients that they're looking at. So from a wound standpoint, from an infection standpoint, and infection rate is going to be related to wound issues. There's a clear, definitive advantage to minimally invasive approaches. And if you just like look at this, like what is it that you would want? I mean, there's a kind of traditional open approach on the left side. You have an 8 to 10 centimeter incision. I mean, you get good visualization certainly, and you can put strong sutures in there versus the central picture. And after so this is a postoperative patient of mine. After I took this picture, I realized I couldn't really see where the incision was, so I blew it up there and circled it so you could see it more clearly. And it's not just this patient. I mean, here's another patient, similar small incision. Got a different patient with a small incision there, and even broke out the ruler for this one so people could believe it when I say it's a 1 centimeter incision. So, you know, um, that's small. And so a lot of advantage there. So if we, interestingly, in that same meta-analysis, they looked at the risk of sural nerve complications. And perhaps unsurprisingly, in the open group, simply if we go back to that picture and look back at this guy right here, I mean, you can see the sural nerve just lateral to the Achilles tendon there. And obviously, if you can see it, you're not going to puncture it or anything. But with minimally invasive approaches, there was a higher rate of sural nerve injury simply because of a lack of visualization. So how can we minimize that risk? Well, visualization is really the issue. I mean, you can try to orient your sutures in a way where you may minimize that risk, but it's still going to be at risk. So you want to be able to see it if you can. So as Ben alluded to earlier, I mean, does ultrasound reduce the rate of sural nerve issues? And there's a couple of papers that have looked at this. This one out of China published in 2020 in 36 patients noted that they had no sural nerve issues whatsoever. A separate paper here this was actually out of Egypt, where it was a single surgeon, but prospective and randomized. And he had some patients that he used ultrasound for, some that he didn't use ultrasound for. And as you can see here, that 4.5% is about what it was in that meta-analysis, but with ultrasound, he had no sural nerve issues. And so there pretty clearly seems to be an advantage there. So what I would say, like, let previous picture aside, I mean, I consider myself an ultrasound novice. I don't really use it in the office. I'm not adept with it. And yet I've used it in these cases, and I think it's really pretty straightforward to use. I mean, the visualization is pretty easy. You can see the tendon very straightforwardly. You can see the sural nerve easily, and you can see your fixation easily, which is really what you need to see in order to accomplish what you're trying to accomplish here. And I've really found it to be pretty intuitive and straightforward, and it doesn't really add a lot of time. In fact, I think it probably makes me more efficient with, passing my needles because I know they're in the right spot. So, once again, you have flexibility in terms of your suture configuration, kind of make it whatever you want, which is important for establishing tension and also maintaining tension. You can basically directly address the two biggest complications that we see with this, which is the wound and sural nerve issues. So I think there's a lot of advantage here. The other thing I would say just as a conclusion, I guess, is that, rehab is important. So it's important to have a very well thought out and explicit rehabilitation protocol so we can make sure we get these people where they need to be. Thank you. All right, so let me stop sharing so I can let Dr. Garras
Thank
fill
you
us
so
in.
much, Thank you so much, Dr. Vosseller. That was a very great presentations. Thank you so much for sharing your experience, and also thank you for pointing out that the ultrasound that was potentially the main that will be the main support to visualizing without hitting the nerves and potential events in the percutaneous repair. Following up, we have Dr. Garras talking about precision and stability for MIS Achilles tendon repair. Dr. Garras, please take away.
Thank you guys. Thanks for having me, and thank you guys for showing up tonight. I'm sure everybody's busy and it's the holiday season, so we appreciate you being here. So I'm going to just concentrate more about the clinical aspect of this system and how I've come to use it. And I remember the first time Ben sat across the table from me and he showed me the system, and I said, no way, I'm not going to use it. It's going to take a lot longer than what I'm currently doing, and I'm not going to do that. And maybe a couple of cocktails later, and him explaining the system to me better, and I thought, okay, you know what? I'll give you one shot. one shot. Let me see how it goes. Okay. Now, before that case came, I had been using MIS for Achilles repairs my entire career. I was a Bob Anderson fellow, so I grew up basically learning how to do MIS. And so I can count the number of open Achilles repairs that I've done on a single hand, and those were for various reasons that had nothing to do with whether they were an MIS candidate or not. But I've always liked MIS because it's a smaller incision, better skin healing. There's a lot less soft tissue disruption, faster return to walking and activities, and less atrophy. And I remember telling Ben, look, in my hands, under the worst circumstances, with everything possibly going wrong, I can do an MIS Achilles in under 20 minutes. Can you beat that? And he goes, well, let's try it. And so I took it and I sat there and I thought about it. Now I'm going to have to pass each needle individually, then go and retrieve each needle individually, and then lock the needles, and then pass additional suture so that I have a 3-strand repair, because that was the criteria that I was going to hold them to. I wanted a 3-strand repair. I did not want a single locking suture. So we thought about it and we came up with a way to do it that actually ended up being faster than what I was doing before. The benefit of using the TendMIN system is it's actually a smaller incision. So what I thought was my cute little 2-3 centimeter transverse incision got smaller. And for once, I actually am happier that something got smaller, right? Better skin healing because it's a longitudinal incision. I've had 0 wound complications in the limited number of cases I've done. Minimal soft tissue disruption, and you can tell that it's a lot less soft tissue disruption because there's a lot less swelling when the patients come back to the office. A lot faster return to activity, absolutely minimal atrophy, and equal strength of the repair. I was impressed. So we decided to show you this technique so that you could see how you can do a 3-strand repair with the same exact technique that you're using. Pass the needles. That's going to be your locking suture, then 2 oblique needles, and you're going to pass the non-looped end of your loops through them. And then you get to use the coolest tool ever, which is the grasper. Probably one of my favorite tools to use in the operating room. I find it very intuitive, very easy to feel the needle and pull it back and then pull the suture out. I know that it looks a lot easier on the dummy, but it really is not that difficult to do once you get the hang of it. Okay, once you've got all 6 strands out, now I'm going to pause here for a second because I want you to pay attention to what he just did. What he did is he passed the locking suture into the loop, and he passed the second suture into it as well. So now you're locking your locking suture as well as passing a second suture through that oblique hole. And you're going to do the same thing on the other side. He's going to pass the locking suture and a second suture at the same time. And now you have a 3-strand repair with a locked stitch up top. The blue one is your locked stitch. The other 2 are sliding stitches, but you've got a 3-strand repair there, okay? That gave me a lot of comfort in my repairs, and I like to do typically an end-to-end repair for a mid-substance. So I'll show you a few examples, but this is what you end up with. You end up with a sub-centimeter incision that barely requires 2 stitches, and I think I was being generous with 2, and a pretty strong repair on the side there. My post-op protocol is pretty simple. 2 weeks rest and relaxation, non-weight bearing. However, I'm probably going to start going away from the non-weight bearing portion. Then they start weight bearing at 2 weeks. They start physical therapy. They're out of the boot by 6 weeks, and they have 0 restrictions by 8 weeks. Now, the beauty of this is the atrophy. And I want you to notice the atrophy on these patients afterwards. This is a patient who is literally 10 weeks out from his Achilles repair, and he is able to not only do a single leg heel rise multiple times. I mean, he's a little shaky, but look at the muscle definition that the gentleman has on his leg. There's almost no atrophy that you can see. Maybe a touch, but not much. Here's another one. This one is a construction worker who's 3 months out from his surgery, able to do a single leg heel rise without any problems at all. This gentleman is an off-duty cop, so very motivated to get back to work. 6 weeks post-op, able to do a bilateral heel rise, and I just saw him a couple of weeks ago, and he's now at 10 weeks and doing a single leg heel rise without any problems. And look at the size of that incision. And here's a 52-year-old laborer who is a smoker. This is probably your perfect patient for an MIS, if I were to say so, because he's a smoker. Less incision, less worrying about his soft tissues, less worrying about infection. And he's able to do his bilateral leg heel rise at 6 weeks. So, it gives you an equal amount of stability and strength compared to other MIS or open techniques. It's a longitudinal incision. So as they start weight bearing and you start stretching that Achilles, your incision doesn't actually spread, it actually tightens up. So that allows for earlier weight bearing and less wound and soft tissue disruption, faster recovery and less atrophy, as you saw in those pictures. And it's actually pretty easy, intuitive, and very reproducible. So MIS is a safe, effective repair compared to open techniques. There's a lot less wound complications and infections, equal strength of the repair that's been shown through the literature time and time again. TendMIN improves on this by creating a longitudinal incision that's even smaller, better healing under weight-bearing tension, less soft tissue disruption, less dissection, and you're able to do the 3-strand locked repair for an end-to-end, or even if you wanted to do an end-to-bone repair. So I think the future of Achilles repairs is actually here. So thank you.
Thank you so much. Thank you so much, Dr. Garras, for the great presentations and then also sharing those fantastic cases. Now we're just moving on to the Q&A sessions, and then Kevin, please take it away.
Sure. Thanks, Ben. Yeah, Dr. Vosseller, Dr. Garras, thanks. Those were both great presentations. My name is Kevin Colbert. I'm the VP Sales Ops at Aztron and manage the Northeast region for the company, and I'll help moderate today's webinar. So we had one audience question, so we can start there. Dr. Doug Wang asked if there has been any noticeable differences in construct strength among ruptures with varied gap sizes. So if either of you have experience there, please chime in.
For an acute Achilles rupture, I don't think it makes any difference. The gap size is just a matter of how far the muscle retracted, right, when it first ruptured. For a more chronic or subacute Achilles rupture, I think that would probably make a bigger difference, in which case you do have to do a little bit of dissecting to free up the proximal stump to bring it down closer to the distal stump. Remember, and Dr. Vosseller said this, our goal here is to actually restore the tension of the Achilles. So you can't leave a gap size, or you can't leave a huge gap behind when you're doing a repair. The whole point of a repair is to actually get that length back to as close to normal as possible. So I don't think it makes a huge difference in an acute setting whatsoever. For a subacute setting, I do think you have to do a little bit of work, and that's regardless of your technique, whether you do MIS or the TendMIN or open repair.
Yeah, I mean, I would agree completely. I think, sometimes too, if you see gap sizing, it would be related to relative dorsiflexion or whatever when you're doing that. So acutely, I don't think it really matters all that much. But yeah, chronic is just a different situation because, the scarring is going to be an issue.
Perfect. So we've had a couple more questions. The second one is, what suture material do you prefer to use, and do you have any knotting issues? I guess just one comment on that. So the system, as Dr. Garras and Vosseller pointed out, is very flexible. You can use it with any suture that you have available. Aztron does kit a ultra high molecular weight polyethylene suture. We also have that available in a size 2 or a 1.2 millimeter tape. It can be used with either of those two options. But Dr. Vosseller and Dr. Garras, what are your preferences?
Yeah, I mean, I've used both. I mean, I've used the tape before, and I've used the ones that they have with it. And this have worked well for me. I mean, I think with any minimally invasive approach, you do have to manage kind of the knots a little bit. So sometimes you may want to, work those into the wound and make sure they're not just all bunched up right there. But I don't think that's unique necessarily to this system. I think that's something you just got to do. But I've not had any issues with that.
Yeah, I'm strictly a suture guy. I don't use tape at all, especially for an MIS repair. I find the knots to be thicker, so I don't love tape. But I haven't had any problems with the suture at all. In the beginning, prior to having a kit that had all the sutures, we were using just regular fiber wire. I think it was number 2 fiber wire to pass through the needles. So, and that worked well. And then now they have the polyethylene suture, which works even better. I find it slides actually a little bit smoother.
Great. There's a follow-up question here on, is there any suture or tape that will not pass through the needle? Ben or Eileen, do you have any experience there?
I can jump on this. The needle will be able to pass any suture or suture tape that is smaller than 1.5 millimeter. So 1.5 tape, any suture tape below, smaller than that size will pass. And then if it doesn't really pass, basically it become a Keith needle where surgeons is gonna pass the end of the suture will bunch up at the shaft of the needle, and then surgeon will be able to use it to grab the lateral side and then pull the suture out, and to grab the medial side and then pull another suture out as a Keith needle. For our experience, the suture size doesn't matter in terms of the whole construct. It's just that if it will be passing through the needle. And something that surgeons do find it interesting that because some surgeons, they want to augment it with bow brace or any type of augmentations. And then with our system, we can actually incorporate that too. So just something that we can potentially talk in the future. But yeah.
Good. So then there's a couple questions here on end-to-end repair versus anchoring repair. Looks like kind of the theme of the question is, when are you preferring to do an end-to-end repair? Are there any difficulties with the TendMIN system in running an end-to-end repair? And then when are you preferring to use an anchor repair? And if you could compare and contrast those two.
Yeah, I'm primarily end to end at this point, unless it's just a really distal rupture, then I'll, do it into some anchors. And I mean, I try to do that on all my repairs, and I have not really encountered any issues. I mean, usually there's sufficient distal tendon that we can get a good enough grab of it.
Yeah, even with maybe about a 3 centimeter stump or even less, you can still typically get your 3 needles in and get a really good grasp with your sutures with an end-to-end repair. I don't use anchors that often. I would say if the stump is really, really short and distal, then it would be the best option to do an anchor repair. But I typically do an end-to-end repair too. I would say 95% of the time.
And Dr. Garras, for the end-to-end repair may be obvious, but in the video you showed, we just did the proximal construct. So you would just flip that and do that same repair in the distal.
Exactly. Yeah. We just showed the proximal construct just for the sake of time, but basically you just repeat the same exact steps on the distal end. And one thing actually that I meant to mention is I don't use ultrasound at all. I think I used it the first case sort of more as a proof of concept that I could find the Achilles tendon without looking. And then I haven't used it since. And I find that the Achilles tendon is fairly palpable. I'm not terribly worried about sural nerve injury. At least I tend to think it's really hard to stab a spaghetti noodle with a fork. It's extremely hard to do that. So as long as you're not holding the nerve down as you're pushing the needle in, it's going to find a way in without getting the nerve. And the nerve is outside the sheath. So as long as you're retrieving the suture inside the sheath, you should not have a problem with it. So I don't use ultrasound at all.
Yeah.
Dr.
You
Garras, sorry, Kevin, I have a
know,
follow-up question, and then potentially from some of our experiences that when you pass all the needle at the same time, and then what's the gap for each needle, and sometimes potentially the compartment or the tissue become pretty tight. How do you navigate the gap and then just to grab the suture all at the same time or grabbing the needle at the same time? Is there any pearls that you can share?
Yeah, so I tend to leave about a centimeter between the first needle, which is your locking suture needle, and the diagonals. And so they tend to be about a centimeter apart. In a perfect world, that's the way I like to do it. And that tends to be just enough to where I can get one at a time without having to worry too much about them getting in the way of each other or becoming an issue, grabbing the wrong one by accident or what have you. But yeah, I would say about a centimeter between your first and then the diagonals, and the diagonals at 30 degrees tend to be about a centimeter apart anyways. So
Mm-hmm. Thank you so much for the sharing. Jumping to another topic, Dr. Vosseller, you mentioned about we were talking about ultrasound, and then we were wondering, you talked about the avoiding the sore nerve injuries, and then is there any pearls that you can share about how to use ultrasound to identify uh, healthy tendon versus non-healthy tendons, or what's the technique that you're using potentially for some of the cases that, for example, mild tendon junction rupture, is there any value that you're seeing for that part? And as well as, is there any pearls that you can share while you're passing needle?
Yeah, I think so. I mean, when I have used other systems in the past, obviously, and I still do, you cycle your sutures afterwards. And I'd say maybe one out of, especially more proximal cases, one out of every 10 or something, you'd cycle them and you just pull them right out. So you just got to redo it basically. And I think this basically eliminates that because you can just see, I mean, it is the proximal ruptures that's more of a concern, but you can just see where you're putting it. So you know you're putting it in the right spot and you can get kind of the more beefy aspect of the tendon, make it more central. And so I think there's some advantage and, at least in some cases, there's going to be some, time saved there because you're just not, you don't have an air ball or something. And I think I mean, like I said, I mean, I'm not going to sit here and give a lecture on ultrasound. I mean, that's not really, my thing, but the main point I would make, I guess, is that I just think it's easy. I mean, it's really not that challenging. It does add some time, and it's certainly true. But it's easy to identify the sural nerve. It's easy to see the Achilles tendon, and I think it probably makes your completion rate, especially for those needle passages that are maybe a little bit more difficult, higher, and in a way where you can avoid one of the things that we're worried about, at least to some degree.
Mm-hmm. Mm-hmm.
and we've seen varying usage of the ultrasound, right? So in certain cases, surgeons are not using it at all. In other cases, they're doing each needle pass with the ultrasound, and then yet a third subset is checking the needle pass after they're doing it with ultrasound to make sure that it's through the midpoint of the tendon. So there is flexibility and depending on your level of comfort with ultrasound, and you can definitely can make that procedure your own. Ben, I was going to jump to we have a number of surgeons on the line that have seen a demo of the TendMIN system and are considering, going for approvals or moving to first cases. Can you both speak to your onboarding, Dr. Garras? You did somewhat in your talk, but Dr. Vosseller did. How did you come about the TendMIN system, and did you do the silicon demo? Did you move to a cadaver lab? What was that prior to your first case?
Yeah, I did the silicon demo, I guess, and worked through that a couple times. And then I mean you know it's similar to other repair systems and things that we're used to doing. So it's not like it's alien or anything like that at all. And so I think it's pretty straightforward um, to gain some confidence with it. Um, and really was more the practicalities of, I have to go to like a specific surgery center because that's the easiest one to get new stuff in, and trying to stay away from the hospital basically. Um, and that's worked. Yeah, I mean it's worked really well for me.
Fantastic. And then in terms of the repair strength, so Dr. Garras, you helped develop the three suture locking construct that you showed today. Can you compare and contrast that with what you were doing prior to the TendMIN procedure, and then what your feel is in terms of the actual repair strength of that construct? The company is working to put out some data and studies that quantify this, but just qualitatively how that
So,
feels.
yeah, so qualitatively feels exactly the same as what I was using before. Basically, it feels just as strong as anything I was doing before. I just saw a question pop up about the earlier weight bearing and why I feel I can do that. And so it actually doesn't have much to do with the repair. So most studies that have been done on MIS repairs or Achilles repairs show that the failure is not really anywhere else but at the knot, right? So if you do a good job tying your knot and locking it appropriately, you don't have as much of the breakdown. That's your weakest point is the knot, right? And so why I feel more comfortable with this, allowing them to weight bear more immediately than waiting the 2 weeks, is because of the longitudinal incision. My biggest fear with letting my prior MIS patients weight bear immediately is they stretch the skin out and open the wound. And I mean, it's rare, but I had a couple that have happened over the years. With this, though, the fact that the incision is longitudinal, as they bear weight, that incision is going to actually go under longitudinal tension and actually compress the incision more rather than spread the incision if it was a horizontal incision. So that's where I'm thinking I'm going to start letting them actually start weight bearing pretty quickly. And as you know, weight bearing is actually a great thing for Achilles tendons in general. That's why even in the non-operative repair or in the non-operative treatment of Achilles tendons, we want them weight bearing earlier, right? So I think I actually think that that's something that I've been toying with that idea for a while, and I think I'm definitely going to move towards an earlier weight bearing phase.
Awesome. So we have more question coming up. Thank you so much, Dr. Vosser. Something that potentially will be something similar that it will be question from the Q&A will be what is the main differences that you're seeing in terms of the outcome compared to other devices currently in the market? And then is there any biomechanical data or any patient outcome or what's the sound of the patients that you haven't heard potentially to really seeing the differences?
Yeah, I think the suture construct that I use is similar. I mean, I use the same construct that, that Dr. Garras developed, and which is similar to things I've used previously, a similar configuration. And so I think that is kind of battle tested and strong and has been, successful in my hands historically. And I think that so underneath the skin, basically it's similar to what I've done before. It's just it's doing it through a much smaller, window, basically. And so I think, in my experience with it, patients love it. I mean, I've had patients that are very, I mean, obviously I explain it to them and introduce it to them, and they're very excited to have such a small incision. I mean, I think for a lot of things, this is kind of, where it's all going to go, right? We're trying to do everything through the smallest incision possible. And we see that on a bunch of different fronts. So I think this is the evolution that we would all kind of expect. And I think it's yeah, I mean, in the patients that I've done, and it's not like I've done a million, but I mean, of the ones that I've done, which is I think about 7 or 8 now, I mean, the and Achilles ruptures are kind of a longer term recovery, so it's hard to speak fully to it because it's I haven't done people that are 6 months out or further, but the people that are the longest out are doing very well and similar to what Dr. Garras presented.
And then, Dr. Vosseller, is there any differences with the system to identify the healthy or non-healthy tendon, or just placing the suture, compared to other MIS technique?
Well, I mean, so, we did an MRI study at one point just showing that most Achilles tendons that rupture are pretty unhealthy. I mean, almost most of the tendon has some degree of tendinosis in it to some degree. Um, However, I do think that the other thing I would say is that most Achilles tendons that rupture in the sagittal plane, so that it's not like it's just like this, they rupture like this. And so there's a kind of zone of injury, if you will. So I think using ultrasound allows you to kind of get outside of that, and you can just see it quite clearly. I mean, once again, I'm an ultrasound novice, but I mean it's quite clear when you're getting to more stout tendon that you can get better fixation in.
I want to add to that too. I want to say that with other MIS systems, you're typically using one of those fork devices to kind of go up the sleeve to retrieve your sutures, right? There's a limit to how far up you can actually go. So when you're talking about that zone of injury, some of those sutures that you're passing are actually right through that zone of injury. You can't go any further up. There's actually you just can't. The forks are only so long. Whereas with this TendMIN system, you can put your sutures as far up as you want, as far away from that zone of injury as you want, because you can retrieve them all the way up to the musculotendinous junction if you felt like it. Does that make sense?
Yeah. Yeah, Dr. Garrett, see, that may actually be the answer to the question that came in the chat, but there was another one if you want to expand on, does having the system jigless enable you to place sutures at strategic locations? How can you place it, in that person's anatomy as opposed to, the median percentile of the
So,
population?
so great question also. And so to that point also, I typically with my diagonals will not go straight parallel to the patient or to the Achilles tendon. I will typically actually lift them up about maybe 10-15 degrees. So they're going they're going proximal to distal, they're angled, but they're also going top to bottom angled about maybe 10-15 degrees, which allows you to actually capture more tendon and avoid the sural nerve on the lateral side.
Yeah, great insight there. Ben, it looks like that's all the questions in the chat.
Awesome. So if there's no, please reach out to us if there's further questions. We will send out the thank you letter after that. But really, really, thank you so much for all the audience to join during this busy of time. And then thank you so much, Dr. Vosseller and Dr. Garras, for sharing such a great, insightful information insight about how we can potentially advance MIS, and then some of the great pros on using new systems, and then to reducing the potential learning curve on that. But sorry, Dr. Garras, please.
I was just going to say, there's one more question that popped up. Any pearls for pre-op? I will say I've actually gotten a lot more adventurous with patient selection, just because I'm not quite as worried about their incision healing as much anymore. I showed you the smoker. I've had a couple of diabetics where I'm not quite as worried about that the wound healing. So I would say I've my selection criteria has actually expanded as a result.
And actually, just to follow up, have you seen how have you seen patient respond after the surgery after using the system? There's a actual question pop up. So just want to ask you final touch on that. How's the patient? What's the voice of the patients? Just curious.
Yeah.
Very favorable. I mean, I will say most people are like, "Are you sure you repaired it?" Because that's a tiny incision. It's actually very favorable. They love how small the incision is. You can barely see it. It almost looks like a little bug bite more than anything, and they can barely see it. So
Yeah, I'd say the
And
same. The other thing too is that when you repair an Achilles, usually you put some tension on it, so there's some pain from that for a couple of days, and then it's just pain from the incision, and usually they don't really have much. So I mean, 2 or 3 days really, they're kind of like, not really having any pain.
yeah.
fantastic. I think that's all we want. That's the thing that we want to hear the most. Just seeing happy patients, and then really great outcome from both of your experience. But thank you so much for your time, Dr. Vosseller and Dr. Garras. Again, sharing all the great insight. We really appreciate it. And thank you everyone for joining. And we'll be having a webinar coming up in the next quarter. So stay tuned, and then looking forward and have a great holiday seasons. Happy early Christmas. Thank you so much, guys. Appreciate it. See you all.
Happy holidays.